And this is our own personal experience. So it's not just a webinar, it's not just a seminar as us five as the panel talking to everybody. It's a place for collective learning, and a place that we can all learn from everybody's experience. So the plan is to have this set up as one of maybe a little bit of a series. So we'll have one maybe in a couple of months, and then maybe 3 throughout the year, with different focused talking points. So the first today, the theme, we kind of want to work through patient experience. So mainly, how do we select a patient who's a good patient candidate, who's maybe not a great candidate, and how do we present this to our patients in an educational but not overwhelming way? And then compare the light adjustable lens to other lenses on the market. So I've got a list of bullet points we'll kind of work through, and I'm hoping that it just feeds into open discussion as a collective group here. So first point, and I'll kind of throw this to Ron and Jenny use as a first talking point. Who is a good patient for the LAL? I mean, who would be an ideal patient? Who would be maybe a poor patient? Who would be somebody that you really wouldn't want to do the light adjustable lens with? Ron, why don't you start that off?
Well, I think, and I'm not sure if this was said, if I missed it or not, but just before I start, that this is really a non-RxSight sponsored event, and all of these will be, and that gives us the opportunity, as Nick alluded to or mentioned earlier, that we could speak off label. So that being said, perfect world scenario, which we know we don't live in a perfect world, but I'd love to see every patient with an 8mm dilated pupil and have just a pristine optical system from, tear film to the retina. Obviously, having a cataract would be helpful. Somebody who's kind of easygoing, but I kind of like the twist of the question that you talked about there, Nick, and that what kind of patient sends a red flag or is somebody that I would not recommend this technology to. And for me, I think that's probably easier to answer. Well, not always. Anybody who has any type of corneal pathology, we have technology that allows us to look at aberrations of the cornea. So anybody who's got any form of ectasia, irregular asymmetric astigmatism, maculopathies, there's kind of a whole slew of things, but really the common denominator, and I might be a little bit more conservative than some of you other folks, but somebody who has high expectations with this wonderful technology, which they often do, they're investing a lot of money. We're giving them blended vision. So if somebody has something going on, no matter what it is, where the eye is not capable of having good acuity post-op, I shy away from that, because again, one eye is going to be dominant distance and one eye is going to be dominant near. And if one of those eyes is not capable of having good acuity, then I may not recommend this technology to them. How about you, Jenny? What are your thoughts?
So I've been doing this for a long time, and I don't get the luxury of picking my patients. So I'm kind of on the other end of the spectrum where I've actually had patients. And again, this is all off label. And this is just kind of real world experience. But a lot of the surgeons have picked patients that have had retinopathy, retinal detachments, macular degeneration, all kinds of things. We're doing patients with keratoconus. But it really opens the door to not only just regular patients that want to be glasses free, but basically patients that are usually excluded from any other premium lens. This is kind of their only option as well. So because we can kind of fine tune it, as long as we are setting up the realistic expectations of, you've had a retinal detachment, you're only correctable at this point. But if you want to get if you want the highest chance of achieving your best visual acuity, then this is probably the best lens for them, because we have 3 up to 4 shots of fine tuning that.
Yeah, I would add to that. I think the important thing for patients to understand is that the controllable variable here is the prescription. It's not necessarily their visual acuity. There's limiting factors to that based on their macular pathology or any corneal pathology, but what we can control is the prescription. So if you could expect a 20/30 outcome with spectacle correction after cataract surgery. We can expect that, if not a little bit better with the LAL. But if you do have macular degeneration or an epiretinal membrane or something like that, that's going to impede that, that still exists. And I think that's an important thing for, at least for us, when we're doing this in our clinic, to make sure that patients understand. And my surgeon and myself both usually will have that discussion to make sure that that horse is beaten dead, make sure that they understand that. And Jenny, you're in a bit of a unique situation because of your open access concept. So you don't really get much of a say. You're kind of handed these patients.
Yes, they're like, here, for example, I had a patient that was hand motion only for several years. And they're like, I think the light adjustable lens would be great. But we got him to 20/60 and he was ecstatic. I mean, he was crying at the end because he's like, I haven't seen under this eye for, years. And just to be able to kind of tap into that just through some light adjustments, he was very happy with it.
Was that something you could,
yeah.
Jenny, could you have done that with a regular, I guess that would be my question, because you have done that with a regular IOL. What was the reason he was 20/60, I guess is what I'm curious about.
Retinal detachment. So no, because when he came in before treatments, they did target Plano, but he was still only 24/400.
Got it.
Yeah, squeezing it out.
So switching it over, maybe, how do we compare the light adjustable lens to other lenses? I mean, we've got Vivity, we've got PanOptics, we've got there's a whole multitude of high-tech lenses out there now, and they all sort of advertise the same thing, which is good optical quality, depth of focus, and ultimately spectacle independence. So Jessica, how would you put the LAL in that? How do you compare contrast to patients who don't have that educational background on what the difference is?
Yeah, I think the area where it's superior to the other multifocal implants is contrast and nighttime issues. So people who come in with nighttime complaints, it's not typically a person you want to put a trifocal, multifocal lens in their eye. So the light adjustable lens is a really good solution for those patients because they have really good nighttime vision. Another situation too is patients that have high angle alpha or angle kappa. I've found they do really well with the light adjustable lens, or just anyone that wants as much glasses independence as possible, but has, maybe doesn't quite fall into the recommended range for a multifocal, whether that's the angle kappa, angle alpha, or maybe they've got a little mild ERM, early macular degeneration. Of course, again, just to emphasize what Jen and Ron mentioned too, this is, of course, off-label, so of course they're, with RxSight, they probably wouldn't recommend for early macular degeneration or an epiretinal membrane, but what I've seen is those patients actually do really well with the light adjustable lens, and if it's mild enough, you can still even do a little blended vision with them, and they don't get the contrast issues.
But you can.
Yeah, I agree with everything you said. We position it. I talk about the optics, especially my folks that are complaining about, nighttime. I ask them, how do you use your eyes? What do you do? A lot of these folks are retired. I'm like, do you road trip a lot? And we talk about the difference between a multifocal and how it works with the zones versus the light adjustable lenses and the blended vision, and I talk about the ranges of vision, and that we can do some fine tuning after it's in there. I also let them know, that this lens, because we're going to customize it, I'm going to see them a little bit more than I would with a multifocal, which is kind of I've never said set it and forget it, but sometimes I think about that. But I present it as the most customizable that we can do. And I do talk about contrast. And so we have several patients with like mild ERMs, and they've done great with these. And we've been able to keep up the contrast that they wouldn't get in some of these other lenses. And we can give them a bigger range than, say, a traditional EDOF like an iHance or something like that. We're going to get a better range. So I talk about, quality of of the image. And they seem to really respond to that.
And
We
I
do the
think,
same thing for glaucoma. So for instance, we had a patient recently who had severe glaucoma, bilateral temporal or bilateral nasal arcuates, significant. And, you know, I've heard talks by surgeons and they would advocate for, you know, that patient's still a multifocal candidate, which I don't know if I would necessarily agree with that. But we definitely went to an LAL and it worked beautifully. Is that something that you would also do in your clinic?
Oh yeah.
Yeah.
Absolutely. Because we're going to make the most of what they have.
Mm-hmm.
And that's the way I present it sometimes.
That's a great point.
if I can chime in there, Nick, I think, you know, the other thing that Ken kind of mentioned there is the ability to have more than one shot at this. And, you know, when back with some of the other EDOF lenses, when we were shooting for a maybe like a mini mono in their non-dominant eye, you know, some people don't tolerate much NISO, or maybe they're happy in the beginning and you get some effective lens positioning change, and now they're not happy, and you know, they're not happy, you know, I'm not happy. I mean, there's really not much, you know, we can do at that point. So to have the ability, you know, to have multiple attempts to get it right, I mean, there's nothing like that, right, in the entire world. So this is really spectacular for us to be able to utilize in that fashion. So
I had an example of that today, this afternoon. In a way, this patient, she is loving, she had her first adjustment and she's loving it. She goes, I know I'm being a little greedy. Can we do just a little bit more near? And she's had one adjustment, you know, and she's like plano and minus 75. I'm like, and I did some trial lenses and stuff. I said, absolutely, we can make a small adjustment. She goes, well, what if I don't like it? I said, that's the beauty. If you don't like it, we'll put you right back where you are and we'll lock it in. And this is a person who, she's some high anxiety, and she's done great with it. As long as I told her everything we were doing and how it was working, even this high anxiety patient, she's like, I just feel so good about this. And we did the adjustment. She's going to try it over the weekend. So.
Right. I mean, this definitely draws that type of individual. My days where I'm doing my LDDs, they're sometimes mentally and emotionally exhausting days. They're rewarding days, but they are. Yeah, I feel it at the end of the day. That 5 o'clock beer is ready for me. But
I think what's really cool with this technology too is these people, they don't believe you. You know, they come in and they're not seeing well at near because you've done no adjustments yet, and maybe they have some uncorrected astigmatism, so even their distance might be a little bit off, and you know, they're kind of skeptical about, okay, I paid all this money, you know, this premium, how am I going to be seeing better? And when you start doing these adjustments, it's really pretty cool to see them, their whole demeanor changes from being a skeptic to, you know, being a believer kind of thing. So it's very, very cool.
Yeah, I've butt heads with a few patients, you know, not by my own doing. They come in, they're kind of unhappy because their vision's not what they want it to be. And, you know, we've never done an adjustment yet, so we have nothing to really be unhappy about. But we're butting heads and they're just mad at me because they feel like I sold them on this thing. And then we become really good friends. I mean, I've had patients email me after, like, I'm sorry, I apologize for the way I was. Yeah, that's okay. But they flip.
Part
and
of
it's
adjustable. Remember, we have to
adjust. The key part there, the key word, it's in the name.
It's in the name.
Yeah. Well, I guess, like, is there any personality traits that you wouldn't do this? I mean, we all work in refractive surgery, so there's definitely red flags that we're all aware of. What kind of individual would you not touch this with?
I'd say the really particular patients, because they will just try to chase that number down, and like the ones, especially that are very perceptive to which eye is seeing what, are big red flags of, they're not going to tolerate much defocus. They're going to know every little change. If you didn't get like a fraction of that quarter corrected, they will be so unhappy. And it's, yeah, so almost like the engineers, but a little bit more extreme, I'd say.
The hyper engineers. Yeah.
Astro.
Yeah.
Yeah. It brings to mind some, you know, I had a guy who literally didn't realize it at the beginning, but he actually made his wife stand and he measured the distance to the road signs of when he could read them. And he would come into me and I was like, wow. I mean, this guy was 2015 and mad. I was like, I just don't, that was a toughie. He was like one of our first 3 we ever did when we were like completely naive.
Yeah.
But we parted friends. It was good. He was 2015, but he was still like going, still think we could get those road signs.
It's almost like, do you guys know the kids book, If You Give a Mouse a Cookie? Do that book? You know that book? It's my son, like one of his favorite books. And it's like that, right? You give a mouse a cookie, it's going to ask for a glass of milk. If you give that engineer 2015, well, they're going to ask for 2010. And that's getting close to humanly impossible. So we sometimes open that can of worms with them. They're 2015 and I'm uncorrected, I'm minus 50. So like 2015, I don't have that uncorrected. And so I'm like sitting there squinting at the board. Like you have better than your eye doctor right now. I do not have that. There is a point where sometimes, yeah, we just did some pretty miraculous stuff. We took you from 2050 to 2015. Let's be happy with that. And there is some coaching there, I think, and some handling.
There's a lot of coaching.
Yeah.
Definitely, watch for those when they come in with that big long list of questions and they're like taking notes on every last thing you say. Think twice about it.
Yes.
Think twice about what you want to, if you want to marry this patient.
Yeah, they are married to you. I've still got those patients coming back, and we've been doing this for 3 years, and they're still my patient. I can't get rid of them. For the most part, it's good, but there's a few that I would rather go away.
How about anybody in the audience, other participants? Any comments?
Anybody else have any pros? We're here to collectively learn. This is not just us talking at everybody. I did have a question come in. Somebody asked if HSV is a contraindication or if anybody does any prophylactic treatment. What do you guys think? I know on label that would be a contraindication, but off label, does anybody have any comments?
We do now because we've had 2 patients that have had reactions. So just prepare for that. If you do a treatment and then their eye turns really red, somewhat painful, just blurry vision the day after treatment usually, or the day of treatment, then that could be a reaction. And we found that it starts resolving fairly quickly once they're on orals. So then instead of waiting for that reaction, and then because then you have to pause the treatments for about a week or 2, we start them on like a very low dose 2 times a day acyclovir before their treatments, and haven't had any issues.
That's what we've done too. Same thing. We would start them on acyclovir, and we'll usually keep them on it for a while, just because it's a safe med and it doesn't really have a high intolerance rate. So BID acyclovir for, I think we do 3 months usually, starting like a month before surgery, just to make sure they're dosed up by the time they get there. Or as soon as we talk to them about surgery, we'll start them on it. Anybody else have any comments?
I've never had an HSV patient, but I did have a patient who was prone to an iritis. And we did her first adjustment and she had a little reaction to it. So we prophylactically used Pred on her and she locked in and is happy as a clam. So, similar situation. It's like, ooh, should have thought of that before we did the first adjustment.
Yeah, I've seen that at the lock-in because the lock-in is it's intense. And I've seen that ignite a bit of an anterior chamber reaction. Nothing dramatic, thankfully, yet, but I'm sure that day will come. But the ones that we have had, just a quick pulse of a steroid goes away, in my experience. But I'm sure there's other cases.
Hi.
Hi.
Hi, how are you? So I work at a practice in Broward in South Florida, and we had a similar case where it was a patient that presented after a second treatment, and it didn't look like your typical HSV. It was just keratitis, painful, blurry red eye. And so at first it was hard to recognize that that's what it was. And so, after treating it a day or 2 with, antibiotics, thinking it was dry eyes, it kind of kicked in. He had a history, of blisters and stuff like that. And so we did right away start the orals, and incredible. He did clear up right away. And then obviously we knew moving forward to keep him on the prophylactic doses.
And
Interesting.
even if they haven't had it in their eye, we even sometimes if they're more prone to cold sores, those are good patients to start them on orals as well.
Yeah, I pulled the trigger pretty quickly on it. If they have any history of anything, even if it hasn't been ocular, I'll just take the med. It's cheap, it's easy. The lock-in is an interesting thing because I've had patients come back with, it looks like photokeratitis almost. And that, I think on a microscopic level, it kind of is that. And I think people who are more light sensitive in general, the fair skinned, blue-eyed individuals tend to be more prone to that. I don't know. Have you guys seen that too?
Yes.
Okay. Yeah.
Yes. I mean, we could clear it pretty quickly, but I was really surprised when I got the phone call after the lock-in. So I warn everybody now.
Okay.
Yeah.
I was gonna ask,
Talk
yeah,
about it.
do you preface it for people? Do you warn them that this process it's painless, but it's not necessarily comfortable. Sometimes, I mean, the light is bright and you may have a lingering, I usually, what I do is I warn my patients that your vision may have a little bit of a dip before it gets back to its normal. So you may notice tomorrow, for instance, if you have your treatment today, that the vision might not be as crisp right away. So don't expect that, but it'll get there. Do you guys preface anything when you're talking to people?
Yes.
When patients come in for their first adjustment, I'll talk to them about expectations after, kind of about the red pink tinge they might experience for 48 hours after, as well as a flare up of dry eye. So I'll typically start all of our patients on artificial tears 4 times a day at that first adjustment. And sometimes if the dry eye is flared up enough, we have to increase to every 2 hours or start a little low to max pulse and postpone an adjustment. So our adjustments are Monday, Thursdays currently. So sometimes they come in on Thursday from Monday and they're still pretty dry, and I'll just get them on low to max, increase the artificial tears as they come back in on Monday as you have scheduled, and we'll just focus on treating the dry eye for now. But I've definitely had patients especially after the lock-in, since the light intensity is so much more, complain about burning, irritation, watery eyes, things like that.
Aching and light sensitivity.
Mm-hmm.
So I think if you want to save your office unnecessary calls, just always let the patients know to expect the worst. And if they don't experience it, it's a win-win for everybody. So I already started lock-in number 1. You're going to lose some vision. If they don't, that's a positive for them. You're going to have light sensitivity. Your eyes might ache. You might see a little bit of double sometimes. So basically I collected all of the complaints that we've heard post lock-in, and then say it'll take twice as long for your eyes to recover. If it only took a day or so the other time, it'll probably take twice as long. And then even after lock-in 2, we had some patients say that their those visual outcomes will lag up to a week, even longer. So just say it'll probably take a full month for everything to really bounce back, but I promise it'll come back. It always does. And I think they just feel so much better then, because I mean, wouldn't you freak out if you start a lock-in process and you lose some vision? So I just tell them, we get it. It's alarming, but it's just part of the process. Like Nick said, it's a super intense light, and your visual system takes a lot longer to recover from it.
So has anybody had, I know we talked about this once before, but post lock-in 2, where it doesn't get better, they have a little myopic shift. I've had 2 patients now, 2 eyes, that ended up being about 0.75 of myopia post lock-in, and I waited literally 3 months to see what would happen. The one guy I put in a contact because it was his distant eye. Has anybody experienced this type of thing? I know, speaking with RxSight, nobody seems to have an answer for that. Anybody in the audience have that type of scenario?
Was this before or after Active Shield?
It was after.
Oh, okay.
So literally, we just PRK'd the one guy I referred to, or his surgery was in November, and we just did PRK on that eye, and he's doing very well, thankfully. But he ended up being about a 0.75.
It may be too early for me to say anything. I just got locked in last Thursday, so I'm less than a week. My first lock-in, nothing changed. My second lock-in on my near eye, I went from -1 to -175. I'm going to wait Nick says, give it a shot, just give it some time, see if it's just the irritation, swelling and such. And so I'll see what it is. Honestly, the -1 to the -175, I'm a very picky German engineer, but honestly, the crispness of the distance eye is so wonderful. And this actually gives me a little bit more near. I was having to hold my iPhone out at about arm's reach to be able to see it. And now if I'm a little bit more myopic, it's actually very easy to see now. So it turns out I'm good either way. And if it does resolve back to the -1, again, I thought it was good then.
What's your distance uncorrected, Walt? Right now, I think you might have mentioned.
Distance uncorrected right eye is 20/15 +2 on the right, and I'm 20/50 +2 for distance, but I'm 20/20 near. And I'm
Gotcha.
actually starting to notice the depth of focus even on the eye that we didn't do it on. I mean, my distance eye can see things up close that I shouldn't be able to see. And if I had just a regular basic lens, I don't think I would.
That's great. I mean, the refraction on the non-dominant eye, especially if you're inducing the added depth of focus, the refraction has a much more loose endpoint. When I'm doing these patients, I mean, it's a lot tougher refraction. So when I have a tech do it, I do all the refractions for the treatments and for everything. But if we do have a patient who comes in post-lock, or, you know, now we're a year out or years out, they'll come in for just refractions for part of an exam. And the refractions are all over the place for my techs, the inexperienced refractions. And don't even try the autorefractor. The autorefractor spit out just bonkers numbers. So I found that, and I think what you're probably still, I know we communicated a little bit earlier today, you're probably still a little early. Give it, like Jenny said, a solid month is definitely, should be plenty of time. I usually tell patients a week or two, then things should definitely rebound and go back to where their normal happy resting spot is. But we used to use the autorefractor a lot. I mean, when we started this journey, we were kind of relying on a little bit more. You know, that was definitely a starting point for the refraction, and it scared the heck out of me, where I saw these patients coming back with like -3 +4 SIL. Like, what is that number? What is that from? And I realized quickly that I had to start my refraction from basically where the last target was and go from there. And it gave me numbers that were way more in line with what I expected. Do you guys feel the same way with that, with the autorefractor?
Yeah.
Okay.
Oh
Yeah.
yeah, definitely. I feel like it picks up a lot of extra astigmatism in my case. And I think a lot of that's related to dry eye, because sometimes it's like irregular astigmatism. And then other than that, yeah, it's I think the axis for us is pretty good. Typically, my axis won't be far off from the autorefractor, but the magnitude of astigmatism and hyperopia and myopia will be a little different for sure.
Okay, that's what I've used it for too, is finding the access if there is one. It's usually within a few, but I know, Jessica, you mentioned putting everybody on teardrops. Does everybody else have a regimen like that, putting people on teardrops? And if you do, what's your preference? Preservative free, preservative? Do you have any brand preferences?
We use Ivisia.
Yeah.
We stick with all preservative free, and I hit them hard every hour.
Okay.
We'll start every hour or 2 hours, and then after I see them, you know, we'll kind of tailor that. But everybody gets preservative free. I have a little sheet with a list of ones that are acceptable, and
Especially now that you have to be a little bit more careful.
Yeah.
Breaks, so.
Yeah.
Luckily, I've always had that list, so my patient's like, okay, none of mine were on that thing because I went by your list. I said, there you go.
Great.
So in our case, we usually pre-treat our patients, definitely with the preservative-free tears, but often we'll be using Restasis, Xiidra, Cequa also in addition, if we can, a couple of weeks before and after. And sometimes even with patients that are very symptomatic right after, and you're trying to, you know, that takes a long time for that Cequa or Xiidra to kick in. I've been even trying the Trevia, this nasal spray, trying to see if we get a quicker improvement on the surface. And so most patients are doing, you know, any of a number of those treatments before and after the surgeries.
Is anybody using the Speed 2 or some type of dry eye questionnaire preoperatively to screen?
In our case, we're not using a questionnaire. We have an HD analyzer. So that gives us like the vision to your breakup time. So sometimes we'll use that, as a guide and just, staining, but we're not necessarily, and we're asking them, but we're not necessarily doing a questionnaire before.
Anybody else?
We just assume everybody has dry eye when they walk in the door.
Yeah.
So I think we'll base our treatment strategy. I mean, everybody's going to get preservative-free tears in our office, at least QID, if not more. Ivizia as a personal preference of mine, but I don't really care as long as it's preservative-free and it's one of the big name brands. I don't want them going towards the Walmart brand or the Walgreens brand. And I usually make them show me what they have. Like a mom with a new kid, show me what you have, prove it to me, and they will. We do a refraction at 1 week, and I kind of base a lot of what I do moving forward based on that and how well they refract. I mean, it is a subjective for me as much as it is for them. I mean, how do they refract? Are they giving crisp answers? Are they giving definitive answers? Is any variability because of just the normal post-operative healing process, or is it because of something else? Is it because of personality issues? Is it something that I'm going to have to delay my treatments now? Because we do every Monday, Thursday, like you do, Jessica, routinely. But if I anticipate that this patient is either going to have a dry eye or if they're going to be just psychologically overwhelmed, we'll extend those out to at least once a week, if not more, depending on how things go. Does everybody pre-schedule LDDs, or do you do it one step at a time? How do you guys all do it?
We schedule all 5 in the beginning.
All 5?
Mm-hmm.
Yeah, we'll schedule 1 week, the 1 day, 1 week, 1 month, and then a couple adjustment schedules, and then go from there depending on where we are. I did want to ask y'all, I occasionally, on the dry eye topic, I'll throw in some temporary plugs on some folks if they're having a flare. Living in Fort Worth, we literally get wind coming from every direction. So we will have different stuff in the air, and I'll have people have flare-ups in the middle of their post-op periods. And I'll use some plugs if all of a sudden we have a real low tear film, but just a temporary set. Does anybody else do that?
That's a good idea. Like a collagen plug that would dissolve. I mean, we just don't have any in the office. We have just the silicone ones. So, but that's not a bad idea. I mean, that wouldn't be a bad idea to almost do on most people. Just,
I've started playing with it just because, I'll just have times where they're like this, their meniscus is really low. It's like, all right, let's do something about that. Especially if they feel like their vision's regressed, but my refractions haven't changed.
Mm-hmm.
Like, let's throw some plugs in there, and then all of a sudden they're back up and we're ready to keep going.
I've done that twice before too, Ken, and I feel like it really helped in my situations as well. Yeah. Typically, of course, artificial tears will be my first line preservative-free. And I have found too that patients prefer preservative-free in a bottle versus the vials.
Yeah.
So I'll recommend Ivizia, Refresh Relieva, because they have a bottle, or the preservative-free, or Sustain Complete. They have a bottle preservative-free too. So the patients like that, so they can just carry around the bottle all day rather than have like 20 vials in their pockets. But there are cases where, I do low to max pulse or do increased artificial tears, and they still have a really decreased tear meniscus, like you said, and I'll put in punctal plugs for those 2 cases, and it helped a lot.
We use Regenerize, and it's a biologic drop that acts like an amniotic membrane and serum tears, and that's pretty fast acting. It's non-steroidal. We had patients that had 3 to 4 plus SBK, and it was all cleaned up within a week of using it. So
are you usually using the Regenerize Light or the professional? Depending
on the severity. Majority of patients are good on light, but those severe cases, like with the 3 plus or higher, Pro, and they only had to use it 3 times a day, and it was resolved.
Cool. Thanks.
Mm-hmm.
Would severe dry eye, do you guys talk to these patients about this before surgery, or is this after surgery's done? Okay, before surgery.
Before.
Do you delay surgery because of it?
If it's interfering with, their measurements, yes, we do. my surgeons will pull me and go, I need you to fix this before we can go. I'm like, all right.
Yeah, if somebody has a lot of SPK, then we'll make sure we clean that up before we do any type of surgery on them.
Okay. Yeah, we try to too. I know. I wish my surgeon was a little more aggressive about it. Sometimes they'll end up in my chair. Like my patients know that once they leave the operating room, they're basically not going to see the surgeon again. They're with me the rest of the time. And I'll get these patients sometimes, and they're definitely, man, I wish we had dealt with this a little more before surgery, but here we are. And then we have to clean up a little bit, but it usually doesn't delay things too much for us. We're able to get through things. And again, I think it comes down to just patient education, make sure that they understand that the light treatments will make their eyes more dry. So it is in your best interest, and collectively us as a team, our best interest to get you to a happy spot. So your job is now to get on this therapy and let's do it. Let's hit it hard to get you to the other side. Then if you don't want to use your tears, I don't care. That's all you, but I want to make sure that my job is I'm doing what I can do to help you. I guess speaking of like the logistics of this, I mean, what do you tell patients when you're talking to them preoperatively about how long this is going to take? When you add up all these visits, they're seeing you 7-8 times if you consider just post-op and surgery days. So how do you tell them to bear with you? How do you win them over when you talk about that? Do you have any comments on that?
I think the key word is adjustable and customizable experience. Yeah, customizable. Once you say that, they're like, I don't care about the commitment to, just to emphasize that this is the only adjustable, intraocular lens. And so prior to this, it was unheard of. It would just be more surgery. So I think they love when you just mention the word, customizable, adjustable, and, the commitment might seem a lot on the forefront, but in the long run, the vision is going to be so worth it.
And emphasize, they're driving the customizable portion of it, and they can go test drive their vision for as long as they want. They can't do that with any other lens.
Yeah, I bring home the because we're going to be adjusting, we're going to see you more. You're going to go beyond the normal couple of post-op visits, but that's because we're not done with surgery. We're gonna continue to refine this until we're happy. And most of the time they're good with that. In fact, I'm having the opposite experience. I'm having patients going, I think I really like this, but how fast do we have to do this? Can I try this a little longer? I'm like, absolutely. Nobody's holding a gun to our head to lock you in. My experience, once they start doing this, they're like, I want to try this just a little bit longer. I love the fact that we don't have to change something today or lock in today. I'm like, sure. And they come back and like, let's lock it in. But they love so I get the opposite end now more than I get can't we just get this done? Because you get some of those. But
yeah, Ken, we're this kind of same mindset where in the beginning we were doing our treatments 3 days apart, and what I was realizing though is Monday and Thursday, and then we started because my thought was everybody wants to get this done, they want to get out of their UV protection, blah blah blah, but what we found is we extend their treatments from 72 hours to a week, because doing Monday and Thursday, a lot of times their habits on the weekends are different, their visual needs and demands and use than during the week. And so now we do a Monday and a Monday. And when we start the lock-in process, though, we do 72 hours apart. But during the treatment phase, we've actually extended the time. And just as long as you explain it that way and the expectation is clear, people are totally fine with waiting longer. Sometimes I'll even say, put your kids in braces for 2 or 3 years. I'm only asking you for, a month or two in UV protection glasses. So.
Yeah, I actually do a week. I tell them, especially on our first adjustment, I'm like, I want you to test drive this for a week, because you do different things on the weekends than you do during the week.
Right.
So a lot of my folks I do now, I have some, but I also let the patient drive it. I'm like, the minimum is 72 hours. But, you know, I usually do a week, but we're going to do what fits in your schedule. And because I'm the outsider here. I don't have a set day I do adjustments. They're in with my regular schedules. We lucked out when we built our new building because we have this great little dilate weight room right next to the room where our LDD sits. So we can see them in the lanes, they dilate, and they're right by one of the tech stations. They just say, you know, they'll keep checking them, when they're dilated, they just grab me and we go in and do it. So I have a little bit of a luxury that way. So I can work around their schedule. And my patients really like it. So I've been lucky that way.
I think
We are
Nick's made
actually,
yeah, go ahead, Jessica.
oh, sorry. We're actually in the process of moving to once a week now, partly because of the feedback that I've heard from all of you guys previously. And I've had several scenarios where I've had to, you know, postpone an adjustment because, for example, I just had a patient on Thursday, last Thursday, who, you know, as he had a great outcome. I was like, you are doing so well. You ready to lock in? And he said, you know, it was on Monday that he came in from Thursday adjustment. And he said, you know, I only had, you know, my vision didn't really come in until Saturday. He's like, so I didn't really get to trial my vision at work on Friday, how it is, you know, now. And he's like, I got to golf, my golfing was great, but he's like, I'd like it a little bit longer in the office to, you know, make sure it works at work too. And so that was Monday from Thursday. And so when he came back in, or I guess this was the week before, because then he came in on that the following Thursday, and he was like, yeah, this is awesome. I'm with you. Let's lock in. But he just needed that ability to have a whole week of work activities and then his weekend of golfing activities to figure out, you know, he truly wanted to lock in. So I think that was kind of a driving force, plus hearing, you know, feedback from all of you, that I really do think that week is key in a lot of cases, and it helps with the dry eye too. So big fan of that.
Does anybody on the flip side, anybody have what's too long? I mean, is there a too long?
I have two comments, if it's okay.
Yeah, of course.
I have we don't have a set schedule, you know, when we set up the, you know, the surgery, and also, if anything, sometimes it may take a little longer, especially if we're collaborating with local ODs, so we'll co-manage. So that's one of the things we encourage our optometrists already educating their patients when they send them in, because we see it as this is the best customizable lens that they can work with their patient and getting to them happy and, you know, on the right prescription. So sometimes, you know, they'll see their OD back a week or two after both, you know, the eye is done. Then once they have a stable refraction, they're doing good, then we'll see them and do the light treatment and send them back to the OD, you know, until, let's say, a week or so later that they're ready for the second eye. Definitely the ones that we do in-house that we're not collaborating, we do a little quicker, and at least we're giving them a week. And then my other question is, as ODs, are you able then to do these light adjustment treatments in your office yourself, or is your MD doing these treatments?
We're doing it.
By yourself.
Yeah.
Mhm.
So I guess I'm the only one in Florida that's not able to do them yet. Because technically, even though it's a UV, I guess it falls in that black, or, you know, that gray area that that we're not allowed to do them yet in the state of Florida.
I think every state is very different. I mean, we crossed that bridge two years ago in Wisconsin.
Mhm.
Wisconsin's a pretty, the OD laws are pretty ambiguous. They're open for interpretation. So we were able to get that. And I think every state's a little bit different. I know Florida can be a little bit stricter, which is unfortunate.
I think as
Right.
far as like how long can we stretch them? I mean, we've had a patient that had extenuating circumstances and couldn't start until a year out. That's not ideal, but they still were able to achieve. We were able to lock them in and everything turned out great. For RK and keratoconus patients, we stretch those out too. So like we try to have at least a refraction in between each treatment, 2 weeks in between every visit. So those really can stretch out to 6 months or longer. And yeah, that's the great thing about the active shields is we don't need to rush the process. But for your average patient, I think they'll probably be locked in within about a month or so.
Yeah, we usually on average we're like 6 weeks, 4 to 6 weeks. I did have one interesting case. Actually, I had a patient who disappeared after her 3rd treatment. I just thought she was done, didn't come back. And I think she ended up getting kind of sick. She was fine, everything's okay, but it was a solid like 3.5 months where she's wandering around unlocked without her glasses on. She thought things were just done. So again, this was not ideal. This is not supposed to happen, but she came back and she was okay. So I think that is a comment on Active Shield being fairly robust to the point where, yeah, there's not much of a concern on the back end. I don't usually like letting patients to have too much time because I think especially this one lady I'm thinking about right now, for instance, she's just overly anxious. And I think you give her too much time, it's doing more harm than good. So I do like putting a little bit of pressure on them to make a decision because the more you think about it, you're just going to go nuts. But I don't think that there really has to be much of a back end. I wouldn't want them to go much more than 6 months on a normal patient, normal healthy eye. With extenuating circumstances, of course, there's that. But otherwise, yeah, I wouldn't want them to go that much longer than that, just because it is cumulative UV exposure that matters.
We still have a patient that hasn't come in for their first treatment, and I think we're coming up on a year now. We've tried calling, we've emailed, we've tried contacting their emergency contact. We were almost going to make a house visit, but I'm like, no one's really willing to go.
Yeah.
So I might have another story. I'll keep you posted, but we're like, we've tried everything. The surgeon's office has tried to call them, and it's like, yeah, so I must be happy, but
yeah.
I guess it happens. Other reps have said, yeah, patients thought they were done. They didn't understand the whole process and then just ghosted.
I guess moving on, I don't want to stay on much more than an hour. I want to respect everybody's time, but last little thing I want to talk about is like case. We think of this as a cataract case or a cataract lens. In our office, we've done plenty of refractive lens exchanges on young people for this. Have you guys done those? Patients without cataracts, has that been successful for everybody? Mm-hmm. What about pre-presbyopes?
Yes.
I think in those cases, sorry.
Go ahead. Yeah, go ahead.
I think in those cases, if they don't, unless they really are decided on blended or monovision, or they have post-refractive surgery, I think we usually would maybe encourage more of a trifocal because they're coming in with more higher demand for perfect reading. So, unless they're pre-surgery, we'll go more that route. So for us, we're recommending this one more like post-surgical. Then we would consider it, I guess, in a young patient, like a clear lens extraction or something like that.
Anybody else?
We've had 10 patients that were clear lens exchanges, all under 40, and yeah, very happy with their near vision. So this lens really opens the door, I feel like, to all ages and all ocular histories, I feel like.
Yeah, we had one not long ago she was a 29-year-old nursing student, high near demand, active individual. She very, hyperopic prescription. She was like a +7 or +8. She came in as a second opinion. She was slated to get a PanOptics by another group in town, and kind of talked her out of it because she had huge pupils. That was going to be a disaster, I think, for her. I was pretty blunt about it. You can do this, and I don't want to put pressure on you, but if I were you, I would do the LAL, and that's what we did. And so we ended up with a target of plano in one eye, and then we nailed that. That was 2015, no problem. And I think we're -1.25 was our final endpoint in the non-dominant. Yeah, and so she was still very happy, and she knew that she was going to need reading glasses for small stuff, but she was functional. As a nurse, she was on her feet doing stuff, and she was able to see. She puts her reading glasses on for starting IVs and that sort of thing, which is no big deal for her. But even in that non-dominant eye, I think she's like 20, 30 plus. I mean, she's still maintaining very functional distance vision. And we could have gone more myopic. She just wanted to, she was thrilled, didn't want to cut it anymore. Anybody else have any experience? Yeah.
We had a similar case like that too at our practice. She was a 29-year-old pharmacist. So she looked at small numbers and like small printouts of prescriptions and dosages and everything, but she still had to, look at the computer for the EHR for the prescriptions coming in and everything. And she ended up wanting to maximize her distance vision though. So she ended up being 20/15 in her distance eye. And she ended up being like 20/30, 20/25 in the near eye, but like J2 up close. But she said with that, she was still able, she's like, I could make out with the J2 prescriptions because she was getting some near from her distance eye too. So I think OU, she was J1. And then she said, just like at the end of the day, if her eyes would get tired, she had a little pair of readers by that she could use, but she was really happy with her vision too.
Do you guys always target blended, like a mono or a blended vision? Does everybody always do that, or do you guys sometimes do bilateral plano?
Sometimes bilateral plano. There's like a very small percent that can't even tolerate, 0.25 to 0.5.
I have one that I did it on because he couldn't tolerate it.
Mm-hmm.
And they still got enough eat off. They were not complaining.
Yeah, this one's crazy.
I've been pleasantly surprised. I've had a couple. Usually it's my male golfers are like the easiest ones. I'd say probably 10% of my patients will do plano on both eyes, but it's usually the men with long arms. They want to be able to see that ball down the fairway, right? And the only thing they care about is seeing the scorecard. I've got a couple of really avid golfers. They want to be able to read their scorecard. Well, you can do that with bilateral plano target usually pretty well. And you can see your ball. And then you can brag about it to your buddies and talk about how you can see your ball down the fairway. But yeah, we do that regularly, depending on personality and visual demands, I suppose.
Yeah, I've been surprised a couple of times we've had patients where I thought for sure we were doing blended vision. And, after they're implanted and they're getting ready for treatments and they're like, you know what, can you just lock me in? I'm pretty happy with where I am right now. And it's like, well, you paid this extra money to have better near vision. Like, oh, I'm good, lock me in. So it's been kind of surprising.
I would say we're the same way as you, Nick, where we have probably about 10% or so that do full distance, both eyes. I had one patient told me, he's like, I don't do anything up close. He's like, I don't read. He's like, I want to see down the road. He's like, I want to see my golf ball. I don't want to see my score on my scorecard. So I was like, okay, let's do it.
Right.
That's an important discussion to have, though. I mean, that's why I really want my patients to be honest with me. And this doesn't work if they're not honest with you. I mean, if you don't have any rapport with them, then there's no point in doing this because you're not going to do it right. You got to be honest. But yeah, guys like that, yeah, I don't read anything. Great. Well, then awesome. We're going to do this. And they rely on you to take what they're telling you and turn it into something tangible. So that's important.
So Nick, can I pose a question? So what do you guys do then as far as, everybody's goals are different for the patient goals. So do you have questionnaires so what do you do to tweak that information out as to what you're thinking you're going to be targeting for these folks? And anybody do questionnaires or you just have a conversation?
Just old-fashioned talking. I talk to everybody before surgery. At least if I don't see them in the exam room, I'll give them a phone call before they even have the operation. Dr. Vukic and I kind of play good cop, bad cop sometimes. He present things in a very, very positive way. And I want to touch base with these patients to make sure that we're also being realistic. But I use that as an opportunity to really gain, well, first of all, introduce myself because I'm going to be spending a lot of time with these people. But then gauge what they like to do, what they, it takes some art to it, I think, getting that out of them, but it's just old-fashioned conversation in our clinic. Anybody else?
We converse. We do some in the pre-op setting, and at our first adjustment visit, we've nailed down the refraction. I'll just roll the chair back and I lean back and say, now let's talk about how you spend your day. How do you use your eyes? What are your hobbies? And I'll sit and have a little conversation with them about what they would like to do. And what do you do for your job? What do you do for fun? And we'll just have the conversation, and then I'll come up with my targets from there.
We're tossing around the idea of starting a questionnaire and either emailing it out before or having them fill it out before their first visit, just to help guide that first visit, to cut down share time, to see if, all right, we could still have that conversation, but cut the time in half, because you can start off, oh, I see that you like to golf, or you play pickleball, so depth perception is going to be important, and then just kind of reiterating that. Or else, like, if they sew a lot, then just let them know you probably won't be able to thread a needle if we want functional vision, and just kind of setting those expectations beforehand. But then you don't have to sit and wait for them to think about what do they do. Sometimes, especially patients that are retired, they have a lot of time, they want to sit and talk to you, but if we want to speed it up, if we know some of this stuff ahead of time.
I mean, that's what we do too, Jenny, is we do have a questionnaire that they fill out, and it's exactly the reason why it kind of guides us. Sometimes, you talk to a patient and they're kind of, not thinking right on the spot, and here when you give a questionnaire, they're at home, they can sit down and fill it out at their leisure. And seems like we get more information from the questionnaire to guide our conversation than if we just were to ask them on the spot. So I was just curious.
Now, did you guys write your own questionnaires, or did you?
That Dell had a questionnaire years ago. We took some of the LASIK questionnaires. We kind of tweaked all these things with some of the earlier premium IOLs and came up with our own version, and just kind of cut and paste kind of thing. So
Yeah, short. You don't want a lot. So
no,
that you don't have to
no, if
wait.
you give too much, right? They're gonna.
And then even think about, if you want to make it even more simple, some of your top 5 categories like golf, pickleball, sewing, recipe, that way if they don't know it, they can circle things too, or write it. But
Jason Ellen in Tulsa, just a question of the group. Does anybody use Veracity?
Yeah.
Zeiss. So it kind of has a pre-questionnaire that just, it's fairly simple. What's most important? Do you want to pay anything out of pocket? I mean, we kind of use that to gauge, even starting the conversation of, I don't want to pay anything out of pocket. Okay, I'm not going to go down the road of anything, versus, and even use what's more important, intermediate or near, of those 2 options. And I think I start my conversation of, if you had to give up, you had to wear glasses for one of your distances, which would you rather do? So which is your least important to have to wear something? Your introverts, engineers, computer users, I don't want to wear anything up close. I don't mind wearing driving glasses, versus I want to see the golf ball, like Nick said, and I'm okay if I have to put on some reading glasses. So I think that kind of cuts down. If you know where they really don't mind wearing something to cheaters, or small task glasses, we call them, I think that gets you the idea of what the 2 other most important parts are as far as their vision for targets, whether they're going to be blended or true mono or bilateral distance.
How do you handle the bold-headed patient who comes in and says, I don't want to wear glasses ever? The question that we all hate.
I say that the Lord made some wonderful lenses for us when we were born. If you want that, man has not created that.
That's really similar.
Man has not created what God gave us, and there's just, I can't give you that.
Yeah, that's what I tell people too. If you come up with that idea and how to make that happen, you're going to make a lot of money. But we don't have it. I haven't figured it out yet. This is pretty close, but there's still stuff to be desired. So I didn't know Veracity had that capability. I don't think we use that. That's good to know.
It's a pre-op. It's a 10-question pre-op questionnaire, and they email that to them before they come in. So they come in the day of, already filled out, and it basically gives you this quick check mark. The technician goes over it. If they haven't filled it out, the front desk or technician can on an iPad, and it just says, is being out of glasses important or not? And if it is, what's most important, intermediate or near? Have you tried monovision? Have you had refractive surgery? Are you willing to pay out of pocket to achieve these without glasses? I think that's the 6 or 7 questions, and really sets the tone really quickly on my discussion before I walk in the door.
Cool.
So,
yeah.
Can I ask a question about some of the difficult patients that we've had it for 6 months now, and my partner that's kind of in the refractive aspect have seen a lot of post refractive surgery patients, LASIK, PRK, RK, the nemesis of everybody. Is anybody pulling back on their treatments for post RK, that first treatment refraction? Say if they're plus 150 for some reason, or plus 1 minus 1, are you backing off that refraction or that first treatment, given the fact of post RK or post LASIK?
Not
haven't.
backing off on that, but
No.
not treating them as soon as you would. So 14 days is too soon to treat a
Right.
post RK. So waiting at least a month or longer. But then I found that they drift more. Like you want to try to hit that plano as soon as you can, because that plus is just going to stick with this RK patient almost the entire time up to the 4th treatment. So if anything, maybe target like minus a quarter possibly. But I wouldn't do anything higher because you don't want to induce any sphere collaboration for them either.
Right. It seems like we're getting more effective treatment than what, and we are waiting 4 weeks before we start. We do a dual refraction, even maybe even PM before doing our first treatments 4 to 6 weeks out. But even then, and it seems that we treat maybe I'd say it's a plus 75 minus 175, but we had some really high SIL patients, but we're getting more treatment for that. So we're ending up like a minus 75 instead of the plus a quarter that we shot for. So I don't know if that's kind of
And then how much time after
in the
that
LASIK world, we would pull that back. We wouldn't treat full plus or treat the full prescription. And so I
How
just
much
didn't know.
time in between do you give them? So you do the treatment and then when do you see them again?
We do 1 week at this minimum, and usually give them another week after that for a dual refraction to make sure they're stable for the second treatment.
It could be that that's too soon. So we wait 2 weeks, do a refraction, then see them again 2 weeks after that. And you'll see that they'll probably drift back to plano or even more plus once you've given them enough time, because their cornea is just so unstable.
Ugly.
Yeah, Jason, time is really on your side for sure. I actually had a 16 cut RK patient.
I'm sorry.
But this was such a cool case. But we had her for 3 months before we fully locked her in, and a lot of it was just waiting. Just like Jen said, sometimes I'd have to wait 2 weeks instead of that 1 week, and I would get an OPD or any type of like a topography, and there's like the manifest refraction at the bottom, and see if that was comparable or if it was changing too, and if I was getting a consistent manifest refraction. But when we first started off with this lens, our practice was all just post-refractive patients. So I definitely can talk to you more about this too. I can give you my contact information, because I've got a lot of cases like that. But time is definitely key. Like if it's still pretty hyperopic or it doesn't make sense with what you're getting on the OPD, then push it out another week, and don't be surprised if you're not locking in for 3 months.
Right.
Yeah. RK patients, I've warned them that they're going to take a long time. We've had a few of those where you come back and the numbers are all over the place. And, I tell them, I can do this treatment if you want me to, but I have no benefit in doing this faster. And you want this to be the rest of your life. So let's just not push it. If you want me to, I will, but I'm taking my hands off this. I'm washing my hands. This is not what I advise. This is against medical advice. And usually when if you're on their side and you've kind of developed that rapport, I think that they get it, that we all have something to gain by waiting.
They do really well, I found too, because they kind of have like a multifocal cornea. So yeah, you'll be really shocked. They'll be like
J1
minus
plus.
75 or minus a quarter or something, and they'll still see really good up close. And I'm like, what is going on? And I realized it was coming from their multifocal cornea. So
yeah, I would never do anything but plano on those patients. I don't know. Those patients are automatic bilateral plano target for me. RK patients, you guys do? Yeah. Because they're getting J1, like you said, Jess. They're J1.
They don't need any
close.
defocus.
No. And I tell them that, over or undersell, over deliver. This is a distance lens, and then they're like, "Well, I can see up close, doc. You lied to me." Yeah, I kind of did, but that's okay.
Yeah, and like Jen said too, sometimes you can increase like the negative spherical aberration too by activating more of that EDOF with a RK cornea. So sometimes less, like plano or minus a quarter, can actually give you more than you would expect, like the 2020, the 16 cut RK 2020 J1. And I was like, thank you, Jesus.
Yeah.
3 months though.
Yeah, those are ones you're like sweating. Holy crap.
Yeah.
That's great. Anybody else have any comments? I mean, I don't want to keep everybody too long. I mean, we all have our evenings to get to. Does anybody else have any last minute things? I plan to do this again. So I want to make this kind of a routine thing. And today was more of a more intimate group just to see how the conversation goes. And then I think with the help of the reps for RxSight, we're going to invite people who have a certain level of experience. This isn't meant to be a sales pitch. I don't work for RxSight. I'm just a user, just like everybody else here. So we want this to be a discussion in a forum of people with a certain level of experience to actually aid in conversation, not just people who, well, how do I turn the LDD on? You know, we don't want that to be the conversation. So I think we'll have one probably sometime June, July, maybe sometime this summer, second quarter. And I mentioned to the original 5 here, if anybody's going to be at ASCRS, let me know. RxSight has expressed some interest in doing like an in-person meeting. They'd like us to have a little bit of an OD network. And I think that'll be awesome to do something in person. So if you do want to, if you're going to be there, let me know. We can try to organize something. I'd love to grab dinner or drinks or something and just network a little bit. So keep me posted if anybody is. So with that, keep a lookout for the next email and I'll be in touch. Otherwise, thanks a lot for joining, guys. Appreciate it. This was good.
Thanks, Nick.
Thanks, everyone.
Thank you.
See you guys.
Appreciate it.